to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe my channel and also please give your valuable comments. So in the last 2 or 3 classes, we are discussing about interpretation of the CBC. How to interpret the CBC. Okay. So we have already seen 2 important cases. One case is related with the iron deficiency anemia, and another case is something related to megaloblastic anemia. So today we will have another important case. So this is a case. This is a 15-month-old baby, male baby, with a pallor since last 4 months. Since last 4 months, child has got the pallor. There is also abdominal distension since last 1 month, and child is born to consanguineous marriage, and child is also from the Mahar community. There is no fever, but there is weight loss, and also there is a history of blood transfusion in the past. On examination, there is a significant failure to thrive. Child is having failure to thrive. Pallor is plus, and also there is gross hepatosplenomegaly. There is also gross hepatosplenomegaly, but there is no any lymphadenopathy. So if you look into this case, some of the points are very important here. One is 15-month-old baby. That means whatever the problem is there, that has been started very early. Okay. And 15-month-old baby now presently having hepatosplenomegaly, massive means. So definitely this would have been started in the very beginning itself. Okay. That's the point number 1. So 15-month-old baby, age factor. Second one is there is a consanguineous marriage. So when you find such a history of consanguineous marriage, now autosomal recessive disorders, maybe thalassemia group of disorders, sickle cell disorder, or other congenital hemolytic disorders, that has to be always suspected. Third one is Mahar community. So when you talk about Mahar community, some of these hematological problems are quite common. So this is another important thing. Now look into the other part. Abdominal distension is there. Okay. So presentation of the patient is abdominal distension. Now abdominal distension, when it occurs, it may be because of the fluid, it may be because of the solid, or it may be because of the gas. Flatus, fluid and solid. Now in this case, that particular abdominal distension which is happening as noticed by the mother, so that is nothing but a hepatosplenomegaly. Another important problem we have to notice that weight loss is there and failure to thrive is there. So weight loss is there and failure to thrive is also, definitely this problem is chronic. Okay, history is also indicative of the same. Although child is in the 15-month-old, but probably from the beginning itself, maybe from the antenatal period also, we don't know. The beginning itself, this problem is carried on. Another important thing which has to be seen is a blood transfusion. There is blood transfusion was given once. That means there is significant pallor is there. Anemia was there previously also. That was treated by the blood transfusion. So this is such a condition where the RBCs are get destructed very rapidly. Now child is having pallor, child is having hepatosplenomegaly, RBCs are destructed rapidly, and weight loss and the history of consanguineous marriage is there, and also Mahar community. These are some of the positive points from the history. So by looking at the history, we can conclude that this looks like a hemolytic anemia. Hepatosplenomegaly, etc. is there. And there may be some acquired or congenital, probably congenital, hereditary, congenital hemolytic problems. Okay, with the massive hepatosplenomegaly. Now come to the important part, that is investigations. Now this is your turn now. Tell me about the investigation and what is the finding. Investigation shows that HB is 3.5 gram, MCV is 75, MCH is 21, MCH is 23, WBC is 60,000, polymorphous 20, lymphocytes 80, platelets 4.3, and LDH, okay, lactose dehydrogenase, so that is 5.500, increased. It is also increased. Now can you tell me the interpretation here? What is the interpretation? Now what is more worried to us is about WBC. WBC is increased enormously, 60,000, isn't it? And the platelets are normal. Platelets are looking normal, 4.3 lakhs. Almost all borderline. But the above picture, HB is 3.5 and MC is 75. That means your mean corpuscular volume is decreased, microcytic. MCH is also 21 and MCHC is also 23. Hemoglobinization and hemoglobin percentage, so both are decreased. So above picture MCH, this is suggestive of hypochromic microcytic anemia. Okay, so that's all about red cell indices. It is hypochromic microcytic anemia. RDW is not given. Now WBC, if you look at WBC is enormous link. WBC is 60,000. Now this is little bit worrying. But if you look at polymorphous, they are 20 and lymphocytes are slightly increased. Platelets are looking normal. Okay. So now this is one of the important finding. And apart from that, LDH is there, that is 5,500. That we will see later. Now look into the case again. First we will see this particular part, that is LDH. Okay, LDH. See, LDH is enormously increased here, 5,500. Okay, usually it is not this much. It's very high. Now first we have to understand LDH, lactohydrogenase. Now there are main 4 causes why which there is LDH will go increase, because whenever you see red cell indices or CBC, LDH also comes together along with that. Okay, because we have to consider LDH also many times, because as we are considering some of the hematological problems, there are, always remember, there are 4 conditions where LDH is increased. Number 1 is megaloblastic anemia. In megaloblastic anemia also LDH will going to increase. Number 2, there are malignancies like leukemias. The LDH will going to increase. Another one is microangiopathies. Some of the microangiopathies, there also LDH will going to increase. Okay. Then last one is histolymphocytic, that is HLH. Okay. So that's one of the hemolytic anemia cause. It's an immunological phenomenon. Actually, one of the histiocytes, like that. So HLH, not able to recall the correct name, full form. Okay, this is one of the immunological modified condition, autoimmune-like condition. So we should know that these are the 4 conditions where the LDH will go into increase. Even in case of megaloblastic anemia also LDH increase. Malignancies like leukemia also it will go into increase. Microangiopathies and HLH. Now with this background, now we go further. Now in this case, there is a blood transfusion in the 4th month. Okay. So जो blood transfusion का जो history है, that was given in the month of 4th month. That means in the 4th month itself, the problem was so severe that blood transfusion was required for the child. Okay. So if the problem is so severe in the 4th month itself, definitely it suggests that this is something related to hereditary. Acquired cases जो है छोटे बच्चों में इतना जल्दी एक blood transfusion को requirement नहीं पूछेगा. But definitely this is a hereditary problem. And if you look into that, HB is very low, it's somewhere around 3.5. MCV is borderline. MCV बहुत ज़्यादा नीचे नहीं है. MCV is बहुत ज़्यादा नीचे नहीं है. So we cannot conclude that this is a iron deficiency anemia. Usually in case of iron deficiency anemia, what happened to MCV in case of iron deficiency anemia? Slightly decreased, microcytic. Okay. Now, but what is more important here is WBC. Okay, WBC. So WBC counts are very high, 60,000. And polymorphous count is also very low. Polymorphous becomes 20 and lymphocytes become 80. So lymphocytes ज़्यादा है 80 है, polymorphous कम है और WBC बहुत ज़्यादा है 60,000 है. Now this being the picture, LDH इधर से बढ़ा हुआ है, इधर से WBC बढ़ा हुआ है, lymphocytes बढ़ा हुआ है और polymorphous कम हुआ है. So कोई भी, when you get this type of picture, it is obvious that everybody think about some of the malignancy, especially leukemia. So this is a point where most of the time we can miss the track. So what is that? Now in this case, again, the PBS was done, peripheral blood smear was done, And in the peripheral blood smear, it is showing that microcytes. That is हमारा MCVB कम है, so microcytes. And hypochromic, yes, okay. And there is also macrocytes, okay. There is also anisocytes, dust-like cells, helmet cells, target cells. So what I mean to say is different type of cells are seen on peripheral blood smear. Microcytes भी है. Meantime there is macrocytes भी है, anisocytes भी है, dust-like cells है. अलग-अलग different size and shape of the cells are seen. Now in between them, there are plenty of nucleated red cells which confuse with the WBC blast cells. Now this is a very important part. Okay, so now peripheral blood smear is showing various size and shape of the RBCs. Okay, and in between them, the plenty of nucleated RBCs are present. We know that RBC should not contain nucleus, isn't it? A mature RBC will not have any, don't have any nucleus. If an RBC is there with the nucleus, that suggests that it is immature. Maybe in the late normoblast or maybe in the intermediate normoblast position it is there. Okay, now what actually happened when you are counting, okay, microscopic counting when we do, usually we consider that RBC is a non-nucleated cell. But sometimes RBCs like late normoblast or early normoblast or intermediate normoblast may appear inside the blood cell with the nucleus, and that will be counted as WBC on counting, because WBCs are always nucleus containing cells. समझ में आ रहा है? All the WBCs, maybe nuclear, that is neutrophils, they are basically the nucleus containing cells. So when such RBCs are also coming with the nucleus, it is actually wrongly counted under the WBCs. Okay, wrongly counted under WBCs. So this should not be confused with the blast cells. इसको जो है हमें WBC बोल के काउंट नहीं करना चाहिए. Actually वो क्या है कि nucleated RBCs which are coming immaturely inside the blood, into the blood. So this confusion will be always there when you are doing this blood count. Okay, so always count how many normoblasts are there for 100 WBC. So इसको जो है कैसे count करना है? Now what is the criteria to avoid this confusion? Okay, normoblast will be always, थोड़ा बहुत normoblast तो आएगा ही, blood smear में तो मिलेगा ही आपको. You cannot avoid it because RBCs are on the process of maturation. So some of the normoblast will definitely come, and you will have some of the nucleated RBCs also come into the smear. So always how to take this as a criteria. Now always count how many normoblasts are there for 100 WBCs. Total अगर 100 WBC है smear में, उसमें से कितना normoblast है? Normoblast means RBC with nucleated cells. वो देखना है. If there are 100 normoblasts for 100 RBC, sorry 100 WBC, 100 WBC cells है और उस स्लाइड में जो है 100 normoblast भी है, nucleated normoblast भी है, then divide the WBC count by half. Then divide the WBC count by half. That means if we have 200 normoblasts, suppose if you have 200 normoblasts for 100 WBC, आपके पास जो गिवन स्लाइड में WBC है 100 है, बट उसी स्लाइड में जो है नॉर्मोब्लास्ट है वो 200 है, देन डिवाइडेड बाय 2/3. सो एक्चुअल काउंट तो इसको डिवाइड करो तो हाफ हो जाएगा. सो जब ये हाफ हो जाएगा, द एक्चुअल काउंट ऑफ WBC नाउ कम डाउन टू 60, फ्रॉम 60,000 to 20,000. आई होप यू अंडरस्टैंड. Many times there will be a confusion in the blood smear whether this is a WBC or whether this is a normoblast. Normoblast means immature RBC because it contains nucleus. Therefore, it creates a confusion. To avoid this confusion, we have to follow a criteria. What is that? If we have in the given slide 200 normoblastic cells are there for every 100 WBC, then divide it by 2/3. 200 into 3, 2, that is 400. 200 divided by into 2, that is 400. 400 divided by 3. 400 divided by 3 कितना हुआ? 1.5 के आसपास. That means, so when you 33. So when you follow this particular rule, then you can get the actual WBC. तो क्वेश्चन यहाँ पे ये कि वो WBC के साथ वो कंफ्यूज कर रहा है. तो इस पिक्चर में एक्चुअली क्या हुआ है, ब्लड पिक्चर में. सो व्हेन दे से इट इज WBC is 600, actually it is not actually the WBC count. They have counted some nucleated normoblast under the same and included it under WBC. Therefore जो है WBC का काउंट बढ़ गया है. ओके, सो therefore this is one important thing that we have to understand. Okay, now further you go. So then what is this case? ठीक है, इस केस में जो है इसका मतलब है कि WBC is not increased. It's not 60,000. Definitely it is somewhere around 20,000 or less than that. ओके, वो इतना ज़्यादा नहीं बढ़ा है. नाउ व्हाट इज दिस केस? दिस केस इज ऑल्सो शोइंग वन मोर इन्वेस्टिगेशन फाइंडिंग, दैट इज hemoglobin, fetal hemoglobin at birth is very high and HbA is 5% and NR, that is normoblasts, are counted as WBC. Okay, तो एक्चुअली दिस इज ए मल्टी साइज मल्टी शेप का RBC वहाँ पे मिल रहा है, एनाइसोसाइटोसिस. एक्चुअली दिस इज ए केस ऑफ एक्चुअली थैलेसीमिया मेजर. इफ यू लुक इनटू दिस स्लाइड यू कैन सी द बेसोफिलिक स्ट्रिपलिंग, बहुत सारी चीज़ इसमें मिल रहा है आपको. नाउ वी हैव ए डिस्कशन. ओके, सो दिस इज अ टिपिकल स्मीयर ऑफ थैलेसीमिया मेजर. ये जो स्मीयर है यहाँ पे, सो दिस इज अ टिपिकल स्मीयर ऑफ थैलेसीमिया मेजर. This is a typical smear of thalassemia major. So what is there? And now go for the electrophoresis. जब आपको पता चल गया कि thalassemia major है, now go for the electrophoresis. So हम बोल सकते हैं तो thalassemia major, why? Because it is one of the congenital hereditary hemolytic problem. We know that. Okay, there is a history of a consanguineous marriage. There is also a history of a Mahar community. और जो भी है community वाला history है. There is also a history of blood transfusion. ओके, आई विल से दिस इज थैलेसीमिया मेजर बिकॉज इफ इट इज माइनर, इतना जल्दी जो है उसको ब्लड ट्रांसफ्यूजन का जरूरत नहीं पड़ेगा. ओके, देयरफॉर इट इज नॉट इंटरमीडिएट और इट इज डेफिनेटली इट इज नॉट माइनर एंड डेफिनेटली इट इज थैलेसीमिया मेजर. नाउ दिस इज अ टिपिकल स्मीयर ऑफ थैलेसीमिया मेजर एंड नाउ यू हैव टू गो फॉर इलेक्ट्रोफोरेसिस. अब आपको इलेक्ट्रोफोरेसिस करना पड़ेगा क्योंकि ये थैलेसीमिया मेजर का जो प्रेजेंटेशन था, इसलिए हमें माइक्रोसाइटिक हाइपोक्रोमिक मिला. MCH वगैरह हम जब देखेंगे तो माइक्रोसाइटिक हाइपोक्रोमिक वाला पिक्चर मिला और हम कंफ्यूज हो गए आयरन डिफिशियंसी एनीमिया के साथ भी टू सम एक्सटेंट. बट व्हेन यू लुक फर्दर, ठीक है, सो इट एमर्ज्ड एज एन थैलेसीमिया मेजर. सो नाउ for the complete diagnosis of thalassemia का जो complete diagnosis करने के लिए now we have to go for the electrophoresis. So electrophoresis means जो है, जो आप ब्लड निकालते हो उसका सीरम है और उसको जो है, जो ब्लड निकालते हो उसको सेंट्रीफ्यूज करना है, उसको फॉर सेंट्रीफ्यूगेशन करना है. Now that we will do. Before that, another condition is sickle cell anemia. Okay, so ये hereditary history है, सब कुछ है, वो sickle cell anemia भी हो सकता है. If it is a case of sickle cell anemia, we will find sickling shape of the RBCs. RBC's shape is not round, not biconcave, not globular, etc. And there will be some sickle shape of the RBC will be seen. Okay. Sickle shape of the RBC will be seen. So now, in case of sickle cell disease, usually we will go for one drug that is called a hydroxyurea. Okay, if the patient is suffering from sickle cell disease, usually we will give a drug called as hydroxyurea in the dose of 10 to 20 milligram per kg. And what is the role of this hydroxyurea is, this should be given as early as possible and given lifelong. इसको जितना जल्दी देना चाहिए और lifelong देना चाहिए. It works by decreasing the hemoglobin F levels as if HbF levels are high in a sickle cell anemia. Now sickle cell anemia and as well as thalassemia, एक में क्वालिटेटिव चेंजेस है और एक में क्वांटिटेटिव चेंजेस है। जैसे थैलेसीमिया है वहाँ पे क्वांटिटेटिव चेंजेस होता है, बट सिकल सेल एनीमिया में क्वालिटेटिव चेंजेस होता है। सो दोनों में हीमोग्लोबिन एफ रहने का चांस है। ओके, सो दैट वी विल डिस्कस लेटर। ओके, नाउ सपोज एक थैलेसीमिया मेजर का पेशेंट है, सपोज सिकल सेल एनीमिया का पेशेंट है, अगर उसका इस ब्लड कंटेनिंग मोर अमाउंट ऑफ हीमोग्लोबिन एफ, HbF type of hemoglobin is present, then by giving hydroxyurea, you can prevent the percentage of sickling cells and you can prevent the chance of sickling crisis. सिकल सेल एनीमिया में तीन चीज़ है, एक सिकल सेल डिसीज, सिकल सेल ट्रेट एंड सिकल सेल crisis. That also a detailed issue that we will see later. So this can be the case if it is a sickle cell disease. Now see, this is what you can see in case of sickle cell disease. जो हैंड और फुट में जो एडिमा और पेनफुल होता है, सो दिस इज यूजुअली सीन इन सिकल सेल क्राइसिस। ठीक है, दैट हैंड पेन है ना, ये लिम्ब पेन, वी कॉल इट एज लिम्ब पेन, सो दैट्स वेरी कैरेक्टरिस्टिक ऑफ सिकल सेल एनीमिया। ओके, सिमिलरली दिस इज सिकलिंग, सी आरबीसी सर गेट सिकलिंग, आरबीसी का जो शेप है वो सिकल हो गया है। ठीक है, दिस इज नथिंग बेस ऑफ सिकलिंग, you can see the RBC shape become sickle, they are not biconcave, they are not even round. So this is sickle cell anemia, वो भी हो सकता है यहाँ पे। If that is the case, we have to go for a hydroxyurea. Now this is target cells. Okay, the patient of liver disorder in HB, you leave it. Now this is spirocytosis. Now here you see the size of the shape of the RBC become round shape. Okay, here the RBC instead of biconcave shape, it is having round shape. Okay, so this is called as a spirocytosis. Now come back to the disease proper. So this is extra information that I have given, but actually this is a case of a thalassemia major. What is confused us in this is this particular blood investigation. ओके, HB कम था, MCV, MCH हमने माइक्रोसाइटिक हाइपोक्रोमिक बोल के उसको डिसाइड कर चुके थे, दैट इज हाइपोक्रोमिक माइक्रोसाइटिक एनीमिया। बट बाय दैट टाइम वी आर इन अ पोजिशन टू डिसाइड वेदर इट इज ए आयरन डिफिशिएंसी एनीमिया और थैलेसीमिया। बट थैलेसीमिया के बारे में सोचने से हमें जो अवॉइड किया वो क्या है कि ये ब्लड रिपोर्ट है, WBC 60,000 एंड दिस LDH इज इंक्रीज्ड। Okay, these are the 2 points. WBC जो 60,000 आया, that we come to the what is the cause, we know that. What is that? It is normal, that means a normoblast containing the nucleus has been also counted as WBC, therefore this report came, इसलिए इसका नंबर बढ़ गया। और LDH तो बढ़ जाता है, LDH तो बहुत सारे कंडीशन में बढ़ जाता है, 5-6 कंडीशन हमने देखा है कि मेगलोब्लास्टिक एनीमिया, मैलिग्नेंसीज, माइक्रोएंजियोपैथीज, हीमोलिटिक एनीमियास एक्सेट्रा। Okay, so if that particular condition is there, it will go into increase. So but this जो WBC count है, that totally confused us, so this should not be done. So this is how actually we have to go for the diagnosis of thalassemia. In the thalassemia, I have told here that we have to go for the electrophoresis के बाद then we come to know the actual fact. Okay, RBC fragility test, we can identify whether it is thalassemia or not. So this is about another important case.